This is our third video on sleep and rest, and I want to talk about sleep apnea, which is basically the cessation of breathing. So breathing stops. It usually happens if you look right here because the tongue or the airway gets closed off. It is definitely connected to higher risks of stroke and heart attack. There are basically three kinds of sleep apnea. Obstructive sleep apnea is the most common. There's a blockway of the airway and soft tissue. Central sleep apnea is where the brain fails to communicate, and then mixed is a combination of both kinds of sleep apnea. If the period of breathing is it has to last longer than 10 seconds for it to be considered apnea. And the severity of the apnea depends on how many events there are per hour, and if they're mild, 5 to 15 seconds, moderate's 15 to 30, and severe's over 30. So if you want to really feel what sleep apnea can do to your heart, take your pulse, and as you're taking your pulse, hold your breath for 30 seconds and watch what happens to your pulse. So if you keep doing that over and over in your sleep, just imagine the pressure that you're putting on your heart. More men are at risk for sleep apnea than women. Usually they're overweight, older than 40, neck size larger than 17, family history of sleep apnea, going through menopause, abnormal facial or neck anatomy, and then dark-skinned, African American, Pacific Island, Mexican, some Asian ethnicities also. It is a condition that may be exacerbated by AFib, diabetes, hypertension, hypercoagulability, and hypothyroidism. Use of CNS depressants, of course, analgesics, as well as our favorite, smoking, can make sleep apnea worse. Again, obstructive sleep apnea is the worst. The uvula and the soft palate collapse. This sometimes happens by weight. Sometimes it happens because of actually like a mouth and jaw problem. There's new studies out there that are saying in a lot of obstructive sleep apnea situations a CPAP is not necessary, but what is necessary is an oral device like that holds your jaw in place while you're sleeping. That's being researched a lot and becoming highly successful. Sleep apnea results in decreased lung capacity or alveolar ventilation, but that means you're not getting the oxygenation that you need, and so you become hypoxic. And once hypoxia starts, it's hard to catch up on what you've missed. One of the hallmarks or telltale signs of sleep apnea is excessive daytime sleepiness. And again, is it technically narcolepsy? Sometimes yes, sometimes no. But people who have sleep apnea tend to need naps during the day. They tend to fall asleep in bizarre situations, and one of the classic symptoms is loud snoring. But to be truly sleep apnea, there has to be loud snoring and then pauses of no breathing at all. So no breathing at all, we're pretty much against that here. But when there's no breathing, the heart rate increases. Again, if you want to know what it feels like to be apneic, hold your breath. See how long you can hold your breath and take your pulse while you're doing it. By the way, don't do that at home if you have any kind of cardiac anomaly. People are diagnosed by a sleep study. They go to the hospital or a sleep center and they're hooked up to all this equipment. It's an EEG, a cardiac monitor. They're looking at all kinds of things at the same time, and people are watching you. I I can't imagine having a sleep study in an institution. However, they do them at home now. They send you a kit that you can hook yourself up to a monitor and it does everything, and then you send it to back to whoever does the kit and they analyze it that way. They're finding that to be far more profitable because people don't sleep well in a hospital setting. And then again, imagine trying to fall asleep with people watching you. To treat this, there are lifestyle changes that have to be made. Again, sometimes they can make an oral device. Weight loss, stop smoking. Weight loss is probably, and smoking are the two biggest ones. A CPAP machine, you can see it here, otherwise known as the Darth Vader mask, really makes it much easier to breathe at night. It keeps the positive air pressure going into the lungs, and it works for about 95% of the patients that have sleep apnea. There's also BiPAP. BiPAP is both positive and negative pressure, so basically it's pushing the alveoli open and then sucking it out and pushing. So it's not ventilation, but it's the step before ventilation. Also, they're finding that tricyclic antidepressants help, and then if it's really severe, they will do surgery. Children can have sleep apnea. They don't always. It's kind of rare, but they can have it. And children who have sleep apnea tend to have more bedwetting problems. Again, we teach all of this simply to discuss the nursing considerations. So what do you think some of the issues are with sleep apnea? First of all, we have to determine how much sleep a patient needs. There are cultural factors involved. We have to talk about the patient-related experience as well as our own personal experiences. You know, how do we feel about sleep? How do we feel about apnea? How do we feel about CPAPs? All those kind of things. We also will encourage a patient to discuss their sleep habits, to put a sleep diary together, and a continual sleep history helps. Once we've found that there is a sleep problem, we need to talk to the patient about any sleep problems they might have. What are their bedtime routines? What's their environment? Dark, door open, door closed. When you're dealing with apnea, you deal a lot with elevation. So do they like to sleep with a lot of pillows, a few pillows? Do they like to be elevated? That's all very important, and these things need to be considered when you're dealing with apnea or any sleep issue. Another big deal with sleep is the hospitalized patient. First of all, they're anxious. The environment's noisy. Their respiratory status is compromised probably. Are there too many visitors? Are there not enough? Are there too many tests? Is there pain? Is there hunger, thirst? Can they get out of bed? Can they not get out of bed? Is there an IV pole beeping beside them? All of those things are really important, and we, because we're advocating for the patient, want to make sure they sleep well. When people fall asleep, they're in an emotional and physical environment of comfort. So if they aren't in that, they're not going to sleep well. I think a couple of these cartoons are kind of cute. I can't sleep, I'm thinking about your math problems. I think that's very funny, especially when I wake myself up in the middle of the night and I'm thinking about you guys and some of your questions and things I want to make sure to connect from the test to the lecture, all those kind of things. And this one is great. You see he's sleeping on a car because you're supposed to sleep on it first. So anyway, sorry for being corny, but I couldn't help it. Okay, so we've tried everything natural first. You know, we want people to not watch stimulating television. We want them to not eat late. We want them to warm milk thing, whatever that kind of stuff is. Anything non-pharmacological first. If that doesn't work, then our next baseline is something like melatonin, which your body makes by itself. And then we get into hypnotics, sedatives, all those kind of things. And there's a list of drugs that's going to be coming up on the next few slides. And again, I'm not going to read all of them to you because you can read yourselves, and they really do explain, each slide explains itself well, and I suggest that you look these classes of drugs up, maybe come up with a couple within that class so that you have an idea what those drugs might entail. But hypnotics provide restful natural sleep. The duration of action allows the client to wake up at their normal time so they don't like over sedate you. They usually provide for natural awakening, no hangover, and there is a danger of becoming tolerant to them, or I don't even want to say addicted, but tolerant. You know, when you take too much medication, it doesn't work anymore. But with them, there's a wide margin of safety, and you can take them for a long time without any issues. Barbiturates are a class of drugs. They suppress the CNS system, and they're usually used for sedative or hypnotic purposes. Don't discontinue them suddenly because they mess with REM sleep. And again, I'm not going to read all the slides. They're all done very well for you, so you have all of them. The next class of drugs is benzodiazepines. There is a very wide safety margin, so you can take this a long time without the risk of overdose or becoming addicted to them. And they have really replaced barbiturates. I can't even tell you the last time I saw a patient on like phenobarb or Seconal or any kind of barbiturate. But benzodiazepines are really good. Again, here's the side effects. I'm not going to read them, but you'll recognize the names: Ativan, Restoril, temazepam. Versed is a very strong benzodiazepine that they use usually preoperative for surgery. And then there are miscellaneous sleep agents, and they, depending on the drug, are effective, not effective, and they include drugs, again, you've heard these names before: Ambien, Lunesta, Sonata, Rezerum, and then over-the-counter drug antihistamines like Benadryl, and again, melatonin. So this is a very brief overview of sleep and rest, but just remember, what are your nursing considerations? And mostly they are to provide the best rest for your patient possible so that they can heal. So as you're learning about sleep and rest and you're going through your notes and you're reading your text, again, care plan so that you can provide a good sleep experience for your patient. Good luck with this content. Again, write down any questions that you might have so that I could answer them for you when we're together.